Fighting Blindness Canada's Viewpoint Education Series shares the latest vision research, provides opportunities for you to ask your questions, and to connect with other people who are living with a blinding eye disease. The session you're about to watch is a recording. To learn more about the research we fund and upcoming programs and events, please visit our website at fightingblindness.ca. Viewpoint is proudly presented by our Platinum partner Bayer and supported by our Gold partner Roche and Silver partners AbbVie, Astellas, Beacon Therapeutics, and Johnson & Johnson. Thank you for watching. We hope you enjoy this session and share your thoughts with us in the comment section below. Exciting lineup this evening. So first up, many of you, if you've attended Viewpoint before, know Dr. Larissa Moniz, who is our Director of Research and Mission Programs. She's going to be having a conversation with Dr. Kenneth Fan about research updates in the Stargardt space. And then we'll be joined by Dr. Kirk Stephenson, and he and Dr. Fan will be answering your questions about Stargardt disease. If at any time you have questions, we encourage you to share them by clicking the Q&A button that's on the bottom of your screen, or you can email us at education@fightingblindness.ca. So just to note, there is the chat and there is the Q&A. We leave the chat open, so if you do want to chat, that's fine. But if you have a question, please try to put them in that Q&A box because it helps us just keep track to make sure that we're answering everyone's question as much as we can. So after our Q&A, we'll be having our new Community Connect session, and I'll be introducing our facilitators, Denise and Taylor, at that time. So that'll be probably around 7:45 that we'll move over and do our Community Connect session, and I'll talk more about how you can join that once we get through here. So for now, enough about me and what I have to say. Let's jump right in. I'd like to invite Dr. Larissa Moniz and Dr. Kenneth Fan to join us and to share a little bit about research. Over to you, Larissa.
Thank you, Morgan, and thank you everyone for joining us. It's so exciting to have this new IRD spotlight, and I think we have such a great group joining us today for this conversation about Stargardt disease. So I will introduce Dr. Kenneth Fan. He is a medical and surgical retina specialist. He completed his training at the Bascom Palmer Eye Institute, which many of you, if you're keeping up to date about clinical trials, may have heard about. He has received prestigious awards and has published over 60 peer-reviewed journal articles. Dr. Fan specializes in inherited retinal diseases and gene therapy, and he offers his expertise at Retina Consultants of Texas in Houston, as well as participating in a number of clinical trials. So welcome, Dr. Fan.
Thank you so much. I'm so happy to be here.
Yeah, thank you. So I'm going to start off just so we're sort of level setting, so we all can get a similar idea about what is Stargardt's disease. I was wondering if you could briefly describe what the disease is.
Sure. So basically, I sort of give this explanation many times a day to my patients. And what I tell them is that Stargardt disease is a hereditary disease by definition. It's a disease that is caused primarily 99% of the time by mutations or variants in the gene ABCA4. And this specific gene, ABCA4, has to be inherited from both parents and passed down to the patient in what we call an autosomal recessive inheritance pattern. And when the patient inherits two variants from each parent of the ABCA4 mutation, they may get Stargardt disease. And Stargardt disease affects primarily the central vision, although not always. And it typically will affect patients very early on. It can be as early as 10 to teenage years, but average age of onset is typically more towards their late 20s, 30s, and 40s. And what happens is, because the protein doesn't work, it's sort of like the assembly line in a factory. So as something is being processed, and in this case, light, if the protein or one of those, assembly line parts is not functioning properly, things start building up behind the assembly line part that's broken. And in this case, these are sort of toxic byproducts that build up under your retina and end up damaging your retina, causing vision loss.
Just a little follow-up from there. You mentioned that when people can get diagnosed or maybe start to see changes in their vision can really vary from the time they're children all the way up into their sort of like adulthood. So I guess you're saying that even though all of the mutations are in, or almost all the mutations are in this one specific gene, it might impact people in very different ways. Is that fair? That it can be
Yes.
very different levels of progression, very different types of vision loss?
That's exactly right. So actually what we call that is it's very heterogeneous. So if you, for example, have the ABCA4 gene is a large gene. It has many, many different exons or components that produce the protein. And if you have a mutation or a variant in one exon, it won't always show in the same way in a patient as a mutation in a different exon.
So where the mutation is can change. So looking at, I know there's, I'm sure still research happening, but if a patient comes to you and they get their genetic testing done, and then you see where the mutations are, does that give you a good sense of maybe how quickly the vision loss will progress or what their experience of vision loss will be?
Usually you can't, unfortunately, pin it down that exactly, although there are some variants that are known to be more mild or late onset or considered more of like a risk factor rather than a damaging variant. But you know, most of the mutations, I would say, we don't fully understand how severe they can be and why they're causing the symptoms they cause.
Okay, thank you. Moving on to which I think is probably going to be one of the more exciting questions for the audience and for me as well. I was wondering if you could tell us a little bit about the clinical trials that are currently underway in this space for Stargardt's disease.
Yeah, this is a huge, huge topic. And I would say this year more than any other, and you know, last year into this year, there's been so much development, just an explosion of people trying to find the first approved therapy for Stargardt. And it's such a big subject that I find it hard to sort of digest. But if you kind of break it down into different categories, it might be a little bit easier to understand. So, um, why don't we break it down by talking about ways that the medicine is like delivered into the body?
Mhm.
Because I find that that can often help patients kind of figure out, oh, this might be something I'd be interested in, or this might be something that sounds really scary and I don't really want to do that. So, and then within each category, you know, of course, there's different stages or phases of each therapy. So um, we can start with maybe something less invasive, so like a pill or an oral
Mhm.
form. I would say that from a systemic or oral standpoint, there's about two companies that are looking at producing some sort of therapy that slows down the progression of Stargardt, but it doesn't really reverse or improve the vision, but it can delay progression significantly. So the one company that's closer to development or actually having a therapy is a company called Alkeus, Alkeus. And they are making a pill that is a special derivative of vitamin A. So it's not vitamin A, but what it does is we know, remember we were talking about that assembly line, the vitamin A byproducts build up. They kind of like form these toxic, what we call dimers, and they kind of damage the retina. And this pill kind of moves them out. It substitutes so that they don't clump up and cause damage. And the initial phase 2 data has been pretty good. And they're looking for FDA approval now, although, you know, time will tell whether this comes to fruition. And I think the most exciting data that Alkeus has shown is um, they've shown data on siblings. So one sibling who's progressed significantly, that has a younger sibling who started the medicine and has not progressed at all since they started the medicine, even by the time they reach the same age as the other sibling who's already symptomatic. So they've treated like maybe 5 to 7 patients like that, and it's all been really, really impressive data. Uh, the next company is a company called Belite Bio, and they're also making a pill that's supposed to reduce accumulation under the retina, mostly targeting young patients, so pediatric patients. And this company, they're in the middle of their phase 3 clinical trial. So, the data is still, we're still waiting for some data readouts. And this one's just a little bit behind Alkeus, but also very promising. The next category, I would say, so going from least invasive to, moderately invasive, is an injection in the eye. And most of the injections in the eye are therapies called optogenetics. And this is a subject even hard for like retina specialists to understand. So the best way I talk to patients about optogenetics is I say that, when you have a damaging retinal disease, the retina, especially the parts that receive and process light called the photoreceptors and the retinal pigmented epithelium, they stop working. And when the light hits the eye, if those don't work, the light never gets processed. It's just a dead end. And what optogenetics is trying to do is place a light sensing molecule, a protein called a channel rhodopsin, which can sense light and switch on and off depending on the light going into the eye. So it finds its way into the retina, and then it serves as the light sensing molecule for that part of the retina. So far, most of the trials are phase 1 or 2, so mostly thinking about dose limitation and deciding what's the best dose for patients. And efficacy data is still to come, but I think it's a really, really novel technology, and people are very excited about it. And right now, we're looking at patients who have really, really low vision, so patients who may see the big E or a little worse than that. But if the technology proves to be very effective, I would say that they'd be looking at helping restore vision for most patients. Now, this technology differs from the oral therapy because it actually helps to restore or regenerate visual potential rather than keeping it stable. So it might be better for patients who have advanced significantly, who are a little bit older. And then the last category is a category of I would say, well, I don't want to say the most invasive, but it kind of is the most invasive, which is surgical therapies, where you basically, and they're all sort of similar. You have some form of technology where you do surgery, and during the surgery, the surgeon implants or injects the medicine into the retina and allows the retina to have a DNA that produces working ABCA4 protein. So this would be good for someone who might be early or moderate severity Stargardt disease, trying to sustain or prevent loss of vision. But of course, you have to go through surgery, and it's obviously a little more invasive, and there's a lot more risks involved with anything that penetrates or goes inside the eye. So there's at least 4 or 5 companies looking at surgical restoration of ABCA4. So this is a very hot area as well.
I think that's really interesting that you distinguish between optogenetics and surgical procedures. Maybe you can explain to me, why would optogenetics not be considered a surgical technique if it's also something that's taking place in the eye?
Yeah, great question. So the reason why I do that is because I've learned over the years that you can have this whole discussion with patients, but what it really comes down to is when you tell the patient what actually is going to happen, they'll often say, whoa, I had no idea that meant you were going to do surgery on my eye, or this or XYZ. So optogenetics, primarily, as far as all of the companies have been developing it now, is what's called an intravitreal injection. So it's just it's a chair side procedure. It's sterile, but it takes like 20 minutes, 15 minutes, and from when you get in the chair to when you leave. And so it's really quick. You don't need any anesthesia. Well, local anesthesia, I should say. And it doesn't hurt. And we do injections all the time for diseases like macular degeneration, diabetes, and that kind of thing, versus the full-on surgery, which is different.
Okay, that makes a lot of sense. and for anybody who's listening, we had one of our community members received Luxturna, which was the first and at this point only gene therapy approved in Canada. And he talks quite a bit in some previous sessions about his experience with the surgery. And it is, quite a involved procedure.
Yep.
Absolutely.
Absolutely.
I thought you broke down those three groups of different treatments really well. So thank you. I know that's like a huge topic to cover. And for anybody listening, we do have information actually about all the trials that Dr. Fan is talking about on our website, on our clinical trials page, or of course you can reach out to the health information line for any more information. But digging into it a little bit more, I was wondering if you could maybe tell me what you are maybe most excited about in all the treatments you're talking about, some that maybe seem maybe most promising, but maybe also closest to coming to market.
Yeah. Why don't I tackle that second question first?
Yeah.
So, Alkeus is the closest, and I'm
Mhm.
super excited about that because their safety profile has looked really good. So it means that you can take this pill with very low risk, and they've shown even in advanced disease like 20 to 30% reduction of growth over time. And that's I know the number doesn't sound, it's not 100%, right? But it's pretty good, and you're not putting anything in your eye, and it's, it just gets eliminated from your body. If it turns out to be actually that safe, it's a no-brainer in my opinion for most patients. But we still have to wait for the real world data and how patients tolerate the medication. So there are asterisks, but I would say that one's the closest to actually being FDA approved. The really home run therapies would be the the surgical like subretinal delivery of ABCA4. So the reason why it's so hard to do that is because, as I mentioned before, the gene is massive. So you can't put the entire DNA in one viral vector of delivery. You have to split it up. So the technology is super complicated. You have to
Mhm.
and you have to inject both in there, and then they have to combine after you get into the cell, and then they have to produce the protein. So like it's far more complicated than Luxturna. So if it works and you can, let's say I'm seeing a patient who's 25 years old and they're starting to notice just a little bit of vision loss, I might be able to treat that patient and say, if I do this, it won't progress because you'll have the working protein. That would be life changing.
Mhm.
Yeah.
Absolutely. And I know we've sometimes talked about this before about how big the ABCA4 gene is, exactly like you're saying. And I know there's different companies trying to get around this problem. There's some that are trying to put in more gene editing. So they're just trying to cut out mutations. There's some that are trying to get rid of splice sites. So quite a bit of exciting things in the market, all at different stages of development. I was wondering about the drug. I think it's super exciting that in this field there is potentially an oral drug that, that could be useful. Would that drug be useful for people who maybe had another type of inherited retinal disease, specifically another type of cone dominant retinal disease, or is it only for individuals with ABCA4 mutations?
It's a good question. So far they've only tested patients with ABCA4. So you can't really expand the label unless you do like a full-on clinical trial. Um, but if you look at the pathways of the where the visual cycle breaks down, you may find that there are other mutations in other genes that result in accumulation of lipofuscin and dimerization of vitamin A, causing
Hmm.
damage. Um, Actually, one of those diseases is macular degeneration,
Hmm.
and that's why they've actually run a trial for geographic atrophy and AMD, which we know is actually like a 50% genetic disease, with
Okay.
all our complement factor H and all of these other things that can cause AMD. But in addition to that, other types of cone rod dystrophies, that can cause vitamin A. They haven't looked at that yet, but I know the company is looking, and we know that in the realm of macular dystrophies, there's like four different mutations that can commonly cause a very similar Stargardt appearance. We know that
Hmm.
PRPH2 mutation is one of those, and foundation fighting blindness has a massive initiative to try to describe this gene and find you know, a treatment for that. There's you know, PROM1 and ELVOLB4. So these are all mutations that look just like Stargardt. So potential targets, but I'm not sure that we can say for sure yet.
Okay, thank you.
Yeah.
We only have a couple more minutes before we're moving on to the next section. So I'll just maybe, based on your experience with clinical trials, I was just wondering if you could sort of tell me what are maybe some of the both opportunities but also hurdles you're seeing researchers face trying to bring new treatments in this rare disease space.
I think the opportunities that I've seen that are just really amazing are the patients. Like patients who have an inherited retinal disease, like my Stargardt patients and RP patients, are so amazing, and they really understand their disease process, and they truly believe that like research is the future. And I've had so many patients, which really touches me a lot, when they say like, even if this doesn't work for me, this is still like maybe for my future generations of family members who might get it, or this other person that I know, or my sibling, right? And I think that that's a huge opportunity for us in clinical trials, because not always do we have patients who are so willing to sacrifice, you know, all their time and of course like the burden of treatment for the advancement of medicine. Biggest hurdles I would say is simply the technology. Like we don't have you know, there's no like how do I say, like Eylea for Stargardt. There's no injection in the eye that you can give that just makes everything go away. And so I believe that if we will get there, I won't put a number of years on it, but I would say on the horizon there will be something that might change the lives of patients. But I think we're not there yet, and it's still a hurdle because the technology is so complex.
Thank you so much. So I am going to turn it over to my colleague Morgan now, and Dr. Fan is going to stick around to answer some of the audience questions. Thank you so much. I've really enjoyed this conversation.
Thank you. Morgan, you're muted.
You're on mute. Yeah.
I still, after 5 years, I still don't get that right. Um, Thank you so much, Larissa and Dr. Fan. That was really interesting. I find all this clinical developments just so fascinating to hear about. So we're going to be joined now by Dr. Kirk Stephenson as well. So Dr. Kirk Stephenson is a retina surgeon who's specializing in inherited retinal diseases, and he's currently finishing up his IRD fellowship here in Toronto at Sick Kids Hospital. He's originally from Vancouver, and he's helped to develop Ireland's national IRD program and has over 45 peer-reviewed publications. So thank you for joining us as well, Dr. Stephenson. Glad to have you here.
Thank you for having me. I'm very excited to see what questions people have.
Me too. So let's dive in. So just as a reminder, there's a couple ways you can ask your questions. So you can put them into the Q&A box that's at the bottom of the screen, or you can email us at education@fightingblindness.ca, and Shani is standing by to grab those questions. We also had some from email that came in before the webinar. So maybe we'll start with one here for Dr. Stephenson from Patricia. So she's asking because her niece has Stargardt disease and she's in college right now and she's studying, but she has quite a bit of eye strain that's happening from all of the different work she's doing between her work and her schoolwork. And do you have any tips or information on how people could navigate some of that physical tiredness or eye strain that comes alongside having an inherited retinal disease?
That's a very practical question. So hopefully this can apply not only to audience members who are affected by Stargardt's or to really anybody. So I know that most universities or all should have an accessibility office. In terms of access to specific needs, that's a great contact point to make. But for day-to-day tips on how one can reduce eye strain, if we think of our eye like a camera, there's two parts, and I'm not referring to a digital camera. If anyone remembers how an old SLR works, you have a lens at the front and the film at the back. I like to keep things basic. It makes sense for me. So the film is your retina, and the lens would be either your lens in the eye, your cornea, or the glasses. We consider them all as one focusing lens. If there's a problem with the ability of the central retina or the macula to pick up light, the other parts of the eye that make up the lens may be trying to compensate by changing focus or trying to overuse these muscles of accommodation. Accommodation is where we look up close at, say, the computer screen or words on a page. So there's a few things that can help. One is to make sure that if someone needs glasses, that they have the right correction. And if they need an ad prescription for near, that they have that at their disposal. But in general, if someone is staring at a computer screen for most of the day, their eyes can become very fatigued and dry. And the reason for this is that when we're concentrating, we don't actually blink as often. So what happens there is that your tears actually dry up in front of your eyes. And there's some simple ways and some more in-depth ways you can address this. But the simplest thing that I wish I could print on the wall or broadcast on the radio is about lid hygiene, as we call it. Not that anyone's eyelids aren't clean. It's just about optimizing the surface. So techniques like heat, a warm compress, which you can either buy in the pharmacy or online, or something much simpler is just a clean face cloth in the shower, actually help to open these glands in your eyelid. It will protect the surface when you're working those long hours. The other thing that can help, probably the last point, would be taking breaks. So there's this concept called the 20-20-20 rule, which is quite difficult to follow. So every 20 minutes, you're supposed to take a break for 20 seconds and look 20 feet in the distance, just to give your eyes a chance to relax. Now, I know in reality, we probably look up every 3 or 4 hours, look off in the distance for 5 minutes while we get a snack, and then come back at longer periods. So just being cognizant of the fact that breaks may be required, that combined with a lid hygiene and making sure you have the right glasses can help some of that strain and fatigue.
Thank you. I think those are just, again, great tips for all of us. I know I remind my little one about that 20-20-20 rule whenever she has the iPad for sure, to get her to look away. I have a couple questions here that related to what Dr. Fan was talking about. So one of our attendees has asked, how long does it take for the intravitreal injection materials to get into the cell and then affect changes in the patient's vision?
I think we're referring to optogenetics technology. Yeah. It's been quoted by the companies that it takes at least a month for there to be visual efficacy of the injection. Now, how much efficacy is still up in the air. We've got some companies where patients go from only seeing light to maybe seeing some shadows, right? We've also got patients who get it and probably don't feel like they improved at all. And this is kind of what I mean by like still a lot of room for growth. But generally speaking, for optogenetics, I mean the protein has to integrate into what we call the ganglion or bipolar cells, and it takes time, and then actually has to start working, so at least several weeks.
And is it a similar timeline for, say, gene therapy? If someone's getting an injection that's a gene therapy?
Yeah, it is. It is. And the post-op course for gene therapy is much more prolonged, right? Like you have oftentimes maybe an air or a partial air bubble, and then you're on an extended course of steroids for several weeks. And oftentimes within a week or two, the patients are still kind of like getting used to having surgery. So it can take longer than that for sure.
That makes sense. Another question about optogenetics, which is always a hot topic, I know whenever it comes up. Anissa's saying, so of the optogenic therapies that you talked about, is there a company that's closer to a final sort of product, especially for people who are older or have more advanced disease?
So the company that's probably the closest is a company called Nanoscope. They're starting their phase 3 this year for Stargardt disease. I think it's called Starlight or Stargaze or something like that. One of those,
I think you're right.
play
That's
on words.
familiar.
Yeah. And you know, we're excited. We're excited to see the efficacy, to see how patients respond with central vision loss. They've done prior trials in RP, which is obviously a totally different mechanism. But you know, looking at how patients with Stargardt's on a larger scale respond to the optogenetics is going to be really interesting.
Absolutely. So there's a question here in the chat, and I'd like to get, you know, both of your takes on this, but maybe we can start with Dr. Stephenson. So Mara's saying, you know, she's done a ton of research after she got her diagnosis, but she's still feeling very unclear about the not role of vitamin B, but if she should be taking vitamin A. So should she completely avoid vitamin A? Is it okay to eat foods with it in her everyday diet? If she's taking supplements that have vitamin A, sort of, is there a protocol, or what is your sort of advice about that? And maybe we can start with Dr. Stephenson.
That's a great question. So most people know that vitamin A is critical to vision, but in Stargardt, as Dr. Fan described, the way in which the body processes vitamin A is, you could say, maybe less efficient than another person. And it would be very difficult in your life to avoid vitamin A altogether. And in fact, it would be harmful to you. So in someone who has a very restricted diet and doesn't take any vitamin A rich foods, they can have symptoms very similar to RP. So our general statement is that if you have a healthy diet, which includes vegetables, like brightly colored vegetables, as well as leafy greens, and people who are able to, eating meat or fish is very helpful, but we recommend not taking a vitamin A supplement in specific. In some cases, we say that more for RP, that taking a multivitamin is fine, but we don't want someone taking 15,000 units of vitamin A, which for the most part, you can only get on prescription. So it would be difficult to access, but where there's a will, there's a will. So we have a little handout at Sick Kids of things to avoid and things to recommend in someone's diet. It's not exactly rocket science, but it is. It's just a little reminder so someone can think back on their daily diet activities.
Are there particular foods that are significantly high in vitamin A that you would want to avoid?
So red meat and liver are supposed to be quite high in vitamin A, as with carrots, as most people would jump to the first on the list. But you probably have to eat 1,000 carrots a day to really overdo it. So if you're able, I'd be pretty interested.
Yeah, absolutely. Dr. Fan, anything to add about vitamin A and its role?
I'd say my practice is very similar to Dr. Stephenson. You know, if you print a list of all foods with vitamin A, the patient's gonna look at you and be like, "You're insane." Like that's, you know, eggs, vegetables, fish. They're like, "How am I supposed to eat healthy?" Like, so I would say restricting your dietary vitamin A is really, really impossible, actually. But I did just go to the Stargardt Summit in Boston, which was not long ago, just a few weeks ago, and there was a very interesting discussion with two other docs, one from Michigan and the other one from Harvard, about checking baseline vitamin A levels, which I'm not necessarily sure that I'm a full proponent of that and putting every patient through that. But if you have a patient who has maybe progressed quickly, or you feel like your eyes are getting worse quickly, it may be something to just check. I had a patient actually who was taking biotin for their hair and skin, and it had supplemental vitamin A. It had like 500% the daily dose, which is not like crazy, but it's still like, you know, it's supplemental A, and they didn't realize it. And they were like, "I feel like my eyes are getting worse." And we went through some of their meds, and we realized that that there was some supplemental vitamin A in their supplements. So I've been more open to talking about diet and supplementation, and even checking vitamin A levels if I feel like, you know, there's questions of what they're actually eating and how high it is at baseline.
That's a very interesting point. Yeah. When you mentioned about the unexpected sources of vitamin A, there's some medications for acne in teenagers that may contain high levels of vitamin A. And recently in Canada, pharmacists are now able to prescribe a certain list of medications without a doctor's prescription. So I haven't seen exactly what they are prescribing, but acne is on the list. So I will investigate this and try and make sure that we pick that up before there's too much exposure.
I always find this conversation really interesting when it comes up around vitamins and supplementation. We talk about this again with macular degeneration as well, often the dry form, and people are taking vitamins. And something that I always find interesting is that, talking about with your doctor what vitamins you're taking, because, you get the question what medications you take, but people may not necessarily associate vitamins with medication. So making sure that you're just talking about all supplementation that you're taking. There's another question here from Sandra, Dr. Stephenson, kind of on the same line here. So are there any sort of everyday health protocols or practices that people with Stargardt could practice to help reduce the impact of the disease?
So another very good practical question. On our same diet advice leaflet, we have a little bit of basic advice about exercise and UV protection. So really the evidence for the maintaining cardiovascular health is that as someone ages, just like you may be at risk for heart disease or stroke, a similar problem can occur in someone's eye. And having Stargardt or any other inherited eye disease doesn't preclude you from having one of these events. So that's something we encourage from a young age. Working in a kids hospital, we could try and encourage that kind of habit because it's much harder to build when you're an adult. And then UV protection. So depending on the person's level of sensitivity to light or photophobia, there's a number of options and none of them are perfect. So one of them is transition lenses that some people love, other people absolutely hate. But it comes down to a little bit of trial and error. Prescription sunglasses are also excellent because we know that UV light can cause damage in anyone's eye. And if someone has a change in their ABCA4 gene, they may be more predisposed to it. And then the dietary changes would be the main thing. I noticed another comment about tints that might be helpful for nighttime in the Q&A. And that's also quite a tricky one. It would be more personalized. So I think the comment was around, well, there's two ways you can approach it. One is looking at glare at nighttime. So if you have headlights and street lights that are causing an issue, that can be quite problematic. The reason people might be sensitive to light is that their cone cells could be more affected than their rods. And that means that what most people might think is a normal level of light might overwhelm that. Using a tint in the dusk or evening hours is pretty tricky because then that limits the amount of light getting to your rod cells. So it's a bit of a balance and depends on the specific circumstance. There's no perfect tint that I'm aware of that would be good in a dim light environment. If anybody has an answer, please share it. Something they've benefited from.
Thank you. So going back to maybe some of the genetics of the Stargardt disease, Katrina is asking in the Q&A, is there any chance of a child getting Stargardt disease if only one of the parents is an ABCA4 gene carrier? And you can go, Dr. Fan, or
Yeah, the likelihood is very, very, very low. But I won't say it's zero. But it's very low. And usually I would say both parents are typically don't test unless there's a patient that actually has the disease, and that's when you reflexively test the parents. But if you're proactive and maybe let's say you've got a cousin or someone that has the disease in the family and you test both parents, I know that I have some patients who have tested their like a fetus in CVS sampling to see if the fetus actually has 2 mutations of ABCA4. So there's always ways to find out, but it's very unlikely if one of the parents does not have the mutation.
Mm-hmm. And I might add to that the reason that there's such great attendance at this meeting is that Stargardt disease is the most common type of inherited eye disease. And the carrier rate in the population, depending on where the study was conducted, is something around the 1 in 30 to 1 in 50 people are a carrier for a change in the ABCA4 gene. And one of the circumstances where one parent may be a known carrier of a mutation and the other parent isn't, but a child could be affected, is if the mutation in the second parent is hiding somewhere. Dr. Fan mentioned exons, which is kind of the blueprint coding part of DNA, whereas introns make up 90%, 98% actually of our DNA. And more, we're finding that the unsolved cases of people with Stargardt disease, the mutation might be hiding in that area. And there's a certain percentage of people that have clinically definite Stargardt disease where we might only be able to find one of the two variants, and the other one is hiding somewhere. So those would be the situations where, despite the evidence before the birth, you may end up with the situation of two ABCA4 mutations.
Thank you. So going back to some of the research, there was a question in the comments about thinking about the oral treatments that you were speaking of, Dr. Fan, would it be appropriate for a child? So they were saying, would their 12-year-old be able to take the pills? So is there age restrictions on any of these treatments? Are the trials happening primarily in adults?
Actually, they're primarily happening in children. So I would say the Belite Bio company is only looking at basically people under the age of 20, so ages 12 to 20. And for Alkeus, I know that they have treated in their sibling study, like kids as young as, I think, like maybe 5 or 6 years old.
Thank you. And there was another question about optogenetics. John was asking sort of what are the risks associated with optogenetics? And I might even broaden that, is that what are some of the risks that, or are there risks that have been seen with some of the clinical studies that you've talked about today?
I mean, to be totally honest, I think we always love to talk about the benefits and the amazing future of these therapies, but there's significant risk for all of them. This includes optogenetics, any surgical therapy, of course. Like we have developed drugs in disease areas of like macular degeneration where a single injection can blind you. And this is after it's been approved by the FDA and deemed safe for patients. And we could have never predicted that until we injected 10,000 people, and then that one unlucky person had a reaction to the drug and they lost their vision. And so with optogenetics, I would say the risk is certainly higher than that, because these are truly like cellular modification drugs. And so, everybody who participates in a clinical trial has to understand all the risks and benefits. It's very important.
Absolutely. Another interesting question about research, and I'd heard about this trial as well. Mara's asking if there's any progress. There was a clinical trial of taking metformin, which I think is probably most commonly known as a drug for diabetes or blood sugar control, to slow down the progression of Stargardt disease.
So from my experience, I haven't heard of any progress in this particular trial, but the drug repurposing is a very enticing approach. It's a drug that's already FDA approved but being used off-label. And this has a number of benefits and applications in other aging diseases. So I think the underlying concept is it allows the part of the eye that processes and gets rid of this toxic vitamin A to help function slightly better. So similarly to the altered vitamin A therapies, it's allowing or slowing down progression. There haven't been any results that I have seen yet, but it's something very exciting because cost-wise would be very enticing again. And the side effect profile is much more tolerable than some of the new experimental treatments.
Dr. Fan, anything to add to that?
Yeah, I mean, I don't think we have any efficacy data on this trial yet. So although it's exciting, I think we have to reserve some judgment.
Wait and see what happens. Yeah, I definitely can see the appeal, especially for a drug that's so widely used already. If that would be effective, that would be really interesting to see. So we have a question, again, I think this one came in by email from Tyler. Sort of thinking about the timeline of treatments, and we've talked about some different things like slowing down progression versus regenerative sort of therapy. And I think he's wondering, is the focus going to shift entirely to prevention with research? If there's a gene therapy to treat people, would then the shift of research be to prevention rather than restoration?
I might start there, Mr. Fan. So I think that having a one-size-fits-all treatment is a nice ideal, but as far as preventions, you look at a gene therapy versus one of the oral therapies. There's a big cost and likely safety difference between the two. So for a gene therapy, it involves a surgery that's about 45 minutes to an hour long. Recovery time is several weeks. And the improvement some people notice between, say, 2 to 4 weeks, using Luxturna as an example. If you can get equal efficacy from an oral vitamin A alternative with no recovery time, no toxicity, providing you're not allergic to the drug, I think that from a regulatory point of view, that's something that's much more likely to be approved than a once-off treatment for each eye that may cost $800,000 to $1 million. So not only are we looking at it from an efficacy point of view, but because Stargardt is such a common condition relative to things like RPE65, which is the disease treated by Luxturna, maximizing the amount of health economic possibility, more of an oral treatment or something that's relatively simple and effective would be more likely to succeed.
So I have a question here we had from email, and this person actually lives in Europe, and they're saying that they feel like the research in Europe is clinically sort of behind where it is in the United States. And I mean, I don't know if that could be said of Canada in terms of behind, but there's maybe less research happening in Canada or less research sites here in Canada. So they're, I guess, maybe expressing some frustration saying like, does one need to live in the US to get quicker access to clinical trials and then intentional, I guess, also potential treatments? And so like as an add-on to that, I'd be interested in both of your perspectives on this. Do you have sort of any advice, or what would you tell patients or families that are navigating Stargardt disease, but might be discouraged by the unavailability of current treatments?
Yeah, this is a good question. I wouldn't necessarily say that Europe is behind. I think that it's just different. Like there are some phase 1-2 clinical trials, maybe not specifically in Stargardt right now, that are being performed out of like Moorfields in London, where they've not approved, but they've had really good positive phase 1 and 2 data in conditions where I have patients who are like, do I need to move to London to get this treatment? So it's the same exact thought process as you are having, I think. And so it's just a matter of it can't be everywhere, right? So they have to choose one place. And there are some companies that are based out of Australia and some that are based, out of Europe and some based out of the United States. Just because of our population and probably where a lot of these companies are based in North America, I think it just tends to be maybe a little bit more common, but there are really, really great clinical trials sites all around the world. So I wouldn't feel discouraged. And on top of that, if you truly feel like you would be a great candidate for a trial and you really want to participate, a lot of these companies will help you financially, like get over to a site. For example, I've got patients from Europe who speak to the sponsor company and they actually fly them over to get treated. So it's not unheard of. It's more rare for sure, but yeah, I wouldn't feel discouraged.
I think the most important thing for people is preparedness for treatments. So having an accurate clinical and genetic diagnosis is critical, because many of the treatments are specifically geared towards a certain genetic condition. There are some gene agnostic treatments where the specific underlying gene isn't critical, but finding that answer is possible in 60 to 70% of people that are affected by IRDs. And then I was just looking at clinicaltrials.gov. This is an active but not recruiting trial for an intravitreal injection of one of the complement inhibitors. And it has 41 sites. Yes, most of them are in States, but it has several sites in France, Germany, Hungary, Israel, Italy. So there is active clinical research ongoing in Europe. And just in the last week, we have a patient from Toronto that's taking part in intravitreal treatment in Germany. So it's actually gone the other way around, where the person's traveled to Europe. So it may be specific to the region where the person resides, but I think linking in with your local IRD specialist and making sure you have the diagnosis as refined as possible to the point where you know the gene is the best way to arm yourself to take part in any relevant trials.
I think that's so interesting, and there's a lot to sort of unpack there. I think that's interesting in terms of, you know, people going over to Europe to get these potential trials, and I think that really speaks to sort of clinical trial and clinical trial design as well, which we've talked a little bit about. But you know, I think it's always important, you know, through our health information line, we talk a lot to people about clinical trials and what's available, and you know, sort of reminding people that these are not necessarily, you know, treatments, they're experiments, and that scientists who are, you know, performing these experiments are looking for very specific set of criteria in the patients that are enrolling in the trial to really get the best information that they can get about a disease or about a potential treatment. So it's interesting that you're saying that patients are actually going over to Europe. Obviously, they really fit the criteria for that study to be included in that work. It's really interesting.
Yeah, it just shows the dedication of both the patient side and the scientist side.
Exactly.
And there's one other thing that came to mind about the ABCA4 gene being so large, is that last time I checked, there's over 2,000 different mutations in that gene, most of which have been linked to causing disease. And there was a great question earlier about, can you predict the progression or the age of onset and all of these clinical features from the gene? And it's very tricky. So there are some variants that are known to be linked to later onset or milder version of the condition, but usually it's a combination of two different mutations that may have a completely different effect on the protein. And it's that unique combination of whichever two out of these 2,000 different variants that will dictate, in part, someone's progression. But there's other factors as well, other genetic landscape that makes up what a person is. Smoking, light exposure, cardiovascular risk. So there's many factors, but it's complicated.
Absolutely. I think that's really interesting too. So you mentioned genetic testing, which I think is a really important thing to touch on as well, in terms of, you know, being ready for potential treatments, having that genetic test. So in Canada, I know genetic testing is typically covered by the provincial governments. It's different in every province. Again, if that's something you're trying to navigate, reach out to Health Info, because we can help you figure out how it works in your province, because it is all a little bit different. But when people get that test, like the tests that are existing currently, are they able to identify all these variants that you were just referring to in terms of the ABCA4 gene?
So in my experience in Canada and in Ireland, they are successful a large percentage of the time. Conservatively, we like to say 60% of people will get an answer with the first type of test. And some people may be a little bit hesitant about genetic testing, which is understandable. It sounds a little bit intimidating. But the typical first line testing we do is with what's called a panel test. So there's about 300, 350 genes that we know of that are linked to inherited eye conditions. And typically we look at those genes specifically. Most of the time we use a commercial partner that helps us do that, because their speed and turnover and accuracy is so far unrivaled. And then about 60% of people would have an answer with that. If we don't find a clear answer, there's a few options that could explain that. One is that what we're looking at is not an inherited condition, and then it mimics it. But the other is that, as we touched on earlier, the cause may be hiding somewhere in the DNA that's not covered by that type of test. So getting access to that in Ontario and in BC, where I've worked, is definitely covered by the provincial government. So I think that's a good first line test, and it can get 60% of people to the point where we might find out what the genetic cause is. A very small proportion of that group might currently have access to either established treatments like Luxturna or clinical trials. But if you haven't reached that stage, it does limit your access to a number of options.
And I've just noticed the time. I'm so engaged in the conversation. We're running out on time here. So I'll ask one more question from our Q&A. One of our attendees is mentioning that their niece has Stargardt's, but their daughter is pregnant. And they're just wondering, should they be concerned with being tested for this mutations? Is this something that can be done, prior to birth? Is it something they should consider? Any thoughts on that?
I'm assuming the niece is pregnant, not the.
No, it says the niece has Stargardt's, but the daughter is pregnant.
Okay.
Yeah.
Okay. The niece has Stargardt's. This is
I know you got to think the tree, the
Okay,
family tree. So the
Carry
person.
the one,
yeah.
Yeah.
So the daughter, so the daughter would only have any a semblance of risk if the person asking the question, who's the mom, actually carries any mutation. So we assume that the mom and the parents of the niece are siblings, right? So there's there's a 50% chance that they're a carrier, right? We know that 25% chance of them having. Hold on, let me do this.
I think you're dead on there.
Yeah,
50%
actually,
chance of the mom having the
yes. So the
the
mom
carrier.
of the niece is a carrier. So then the mom who's asking the question has a chance of being a carrier too, but there's a much lower chance of the daughter getting the ABCA4 variant from the mom, right? So if, in my opinion, and this is what I tell patients, if you're truly super, super curious, go ahead and get the test. But better to just see a retina specialist. And if there's not even an inkling of any change on your eye, the likelihood is very low. And if you do have something and you get tested and you actually are carrying the mutation, which Dr. Stephenson already said, 1 in 30 patients carry the mutation. And in the US, they say it's like 1 in 20. So you could just test a random person and find something and freak out about it. But if you have no symptoms, then it's less likely that it's actually damaging or pathogenic. If you do have it, you can always test the father of the child.
Yeah, it's a complex question there, especially you did a great job working it out in your head there. So I think it's like 50% chance that the mom is a carrier, then 50% chance if she's a carrier that the daughter has it, and this daughter is pregnant. And depending on the partner's ABCA4 status, there's like a 1 in 30 chance. So multiply that all together. It's not a zero, but it's less likely. And then ways of testing. So the person in question is pregnant already. So there's non-invasive prenatal testing, which has its limitations. I'm not an expert in this area, but it's something to look into. And then, as you say, Dr. Fan, I think just examining the pregnant mom, and the child later on in life is the best way to find out for sure, because some of these prenatal testing techniques have risk of causing a miscarriage.
And I think it's important to know too that these genetic tests, even going back to our previous conversation about, getting genetic, even if you have diagnosis of Stargardt's and then getting a genetic test, it's really important that when you get this testing, you also have access to genetic counselors, genetic specialists who can talk you through what those results actually mean. Because like you said, it could be there, but not be, clinically meaningful, so to speak. So I think that's important to note as well. Well, thank you so much. That just flew by, Dr. Fan, Dr. Stevenson. I really appreciate all of your answers, and that mental math was very impressive. I'm in awe because I you lost me early on.
I lost myself there for a second too.
Well, thank you both so much for being here. We really appreciate it. And yeah, thanks again.
Yeah, thanks
Thank you for having us.
Yes, it's great.
Amazing. So we're going to now move to the next part of our session. So as I mentioned at the beginning of tonight, we're piloting this new series that we're calling IRD Spotlight. So we're including our research updates, asking our expert, which is what we've all kind of come to know and love and expect from Viewpoint. But we're adding this new element where we're hoping to sort of connect you with others in the IRD community. So shortly, we're going to be moving from this webinar platform over to meeting rooms where you can engage with and meet other people and families who are affected by Stargardt. So this session that we're in right now, someone had asked a question earlier. This has been recorded. We will be sharing this recording. But our sessions that are going to happen in the meeting rooms are not recorded. And those are just for us to have some conversations. So when we go over there, we have two wonderful moderators who are both people who are living with Stargardt. And I'd like to take the opportunity to introduce them to you now and hear a little bit about them before we move over. So we have two moderators. Our first is Denise Justin, who's been a longtime friend of us at Fighting Blindness Canada. She's a businesswoman, a health and fitness lover, a devoted and proud mother, sister, aunt, friend. And she just also happens to live with Stargardt disease. And then, of course, we have our second moderator, Taylor Gaudon, who is a virtual program coordinator at CNIB Lake Joe, and very passionate about the profound impact recreation can have on people living with blindness. Taylor was diagnosed with Stargardt's when she was 12 years old and is really eager to help share her journey and help empower others. So thank you both so much for joining us as well today. And so I'd love to just give you both the opportunity, maybe 3 or 4 minutes each. Just want to invite you to introduce yourself, tell us a little bit about who you are, when you were diagnosed, how it sort of affects you, and then maybe a little bit about what you're hoping to share and bring to our sessions or breakout sessions. So Denise, I see you up on my screen. So how about we start with you? Would you like to introduce yourself?
I certainly would. Thank you, Morgan. Hello, everyone. I'm really thrilled and honored to be here, excited for this, and thoroughly enjoyed what we just listened to. It was fascinating. And, that hope, that's what keeps us going. I'm going to start with a little trivia. Have you ever wondered why Stargardts? Why the name Stargardt? And 116 years ago, a doctor in Germany, Dr. Karl Stargardt, was the first person to describe the condition. And he based this on his own practice and patients he was seeing. So I thought that was very interesting. So that was 116 years ago. 13 years ago, I was diagnosed. And I'll just quickly go through. So 13 years, I was diagnosed. 8 years, I hung up my car keys. 7 years ago, I decided that my career, I'm going to use the word pivot, get ready. 7 years ago, I decided that my career needed to pivot. It was corporate and it was becoming difficult. 2 years ago could be my most challenging transition. I purchased the white cane and I use it for travel. Anyone who's been to Pearson Airport, Union Station, what I have discovered with this white cane, it is so empowering. I feel calm. People are so kind. And I will add that the VIP treatment is incredible. So now I can happily say, my vision has decreased, certainly, from 13 years ago. Now I am working as a bookkeeper. I define myself as a solid solo traveler and an advocate for those of us with vision loss and blindness. The emotions that you go through at every transition, it's similar to the stages of grief. I've been through them. I've sought help, resources. So that will take us into the breakout group where we can chat about that and your support. So thank you very much. I'm excited to be here.
Thanks, Denise, I'm so happy to have you here and to be part of our breakout sessions and have more of a chance to chat. Taylor, I would invite you to do the same if you'd like to introduce yourself and share a little bit about your journey with everyone.
Of course. Thank you so much. It is a pleasure to be here tonight and alongside Denise as well. That was fun trivia. I did not know that. So thank you for sharing that, Denise. As Morgan mentioned, my name is Taylor. I'm 25 years old and I was diagnosed with Stargardt's when I was 12, which also happens to be 13 years ago. So that's another thing we have in common, Denise. It was a long road to reach that diagnosis. It was very emotional and very challenging to reach that point. When I was diagnosed, a great challenge that I faced was that I didn't know anybody in my life and had never met anybody with blindness or vision loss. So I had no idea what it was like, and I had no idea what to expect for the rest of my life. And at the time, I only felt like I could grieve the loss of the person that I was supposed to be before I was diagnosed. And so another challenge was that at 12 years old, you start to develop that awareness of social identity. And I wanted nothing more than to just blend in with my peers. And so I actually refused a lot of the supports and supports and equipment and opportunities that were offered to me. But no matter what, my parents always made sure that I was aware of all of the things that were available to me, all of the support, and they allowed me that space to come to terms with things in my own time, which I am very grateful for to this day. And so when I was 17, I took on my first job at CNIB Lake Joe, a camp in Muskoka here in Ontario for the blind and people with vision loss. And that summer changed my life. It was my very first introduction to the community. And the people that I was able to meet that summer made me realize that being diagnosed with Stargardt's did not mean that I lost the person that I was supposed to be, but rather introduced to discovering the person that I am supposed to be and will end up being. And that summer empowered me to carry on with my life and carve out the life that I wanted for myself. And so I went on to get a degree in film and television. And by the time I was done that journey, I had realized that I am most passionate about serving my community and working within the community. So since 2022, I've been working full-time with CNIB Lake Joe, running the virtual program department, which was created in 2020. And I'm also simultaneously working towards my diploma in recreation and leisure services. Um, and yeah, now I willingly accept all of the supports that are offered to me in my life from my family, my friends, and my partner Erin, who I live here in Ottawa with. And I still pursue all of the things that I have always loved since I was a child before my diagnosis. So art, music, cooking. I love hiking and going for long walks and taking the bus anywhere that I feel like I would like to go with my white cane in hand. So it's like I said, it's an absolute pleasure to be here tonight, and I'm very passionate about sharing my journey because I know that a lot of children diagnosed with Stargardt's can connect with my journey, and if there's anything that I can share to help validate or empower your journey or your loved one's journey, I am happy to do so. So thank you so much.
That's wonderful. Thank you, Taylor. It's such a pleasure to actually meet you. I think
Yes.
we've had exchanged emails and things over the years, so it's really lovely to have you here.